Thoracic Outlet Syndrome. This is another surgery that I do quite a bit of that is very enjoyable. It's a technically complicated surgery. The interesting thing about thoracic outlet syndrome is there's sort of three types. There's an arterial type, a venous type, and then a nerve type. Of all those types, the arterial and venous types of thoracic outlet syndrome are combined are about 5%. The other 95% of thoracic outlet syndrome is neurogenic, so involving the nerves. The interesting thing is that even though neurogenic thoracic outlet syndrome makes up 95% of all thoracic outlet syndrome patients, it's by far the hardest to diagnose. The nerves involved go to so many different areas that a lot of these patients will be misdiagnosed as having other little things, or their doctors will sort of start to focus in on a certain area that they may understand and sort of forget the rest. And that stems because they don't understand, the nerves. Neurogenic thoracic outlet syndrome, you can have symptoms ranging from pain in the lateral neck. You can have cervical pain, facial jaw pain. Very commonly, these patients will have sort of a posterior headache on the affected side that comes up into the lateral base of the skull and extends up over the ear and can come into the eye. Very common feature is pain that radiates down into the upper back between the spine and the shoulder blade, the scapula. Pain can radiate over the scapula. You can get pain that comes up into the armpit or into the chest here. Breast pain or upper chest pain, and then shoulder pain is a big feature, and then literally any types of symptoms you can imagine into the arm: numbness, tingling, weakness, burning, etc., because that's where nerve branches from the brachial plexus go to that entire area. The facial and headache stuff, really, those nerves don't come from the brachial plexus. They come off the cervical plexus, which is just the nerve roots just above the brachial plexus nerve roots. And so you get a referral of pain to the cervical plexus, which usually resolves once you decompress the brachial plexus. The historical thinking about this condition is that the primary compression was between the rib and the clavicle, where the nerves pass between those two structures. The old operation involves removing the first rib, which is a very morbid, dangerous step in surgery that's really not necessary. The compression in somebody with neurogenic outlet syndrome is soft tissue between the anterior and middle scalene muscles. That's not to say that you couldn't have somebody who needed a first rib resection, but those patients are going to be super rare. But really what the operation requires is removal of the anterior and middle scalene muscles, and then a careful neuroplasty of all the different components of the brachial plexus, which is a very sort of complex web of nerves between the cervical spine and sort of the shoulder area.